Gillums. I am the Chief Advocacy Officer for AMVETS and also United States Marine. For those of us who sit on the front lines of the effort to curb veteran suicide, the release of the Prevents Roadmap was highly anticipated. While veteran suicide has remained a priority for AMVETS for the last several years, we are finally seeing what we believe is the answer, a collective impact approach that calls upon all of us to get involved and be a part of the solution. With that in mind, it's important to make a distinction right off the bat. A roadmap is one thing, an action plan is another. This roadmap is a framework that calls upon multiple parts of society to develop ideas from a common blueprint. But action is a realization of the intent of a roadmap, and outcomes are the true overall purpose. Without the outcomes, the roadmap loses its ultimate purpose, and it will well equally serve us to never have had the roadmap in the first place. I will now discuss the Prevents Roadmap in its main three parts: recommendations, implementation, and evaluation. Starting with the recommendations put forth by subject matter experts to include AMVETS, the Defense Department, and the Prevents Task Force that was commissioned by the executive order. So let's start with the first recommendation: to create and implement a national public health campaign focused on suicide preventions for veterans and all Americans. Up until now, the conversation on suicide had exclusively focused on veterans and service members. If you work or advocated within the veteran space, the 22 veterans a day call to action became a household term. Therein lied the problem. Between all the 22 push-up challenges, 22 mile runs, $22 fundraisers, and number of times someone has said 22 veterans will die by suicide today as an attention grabber in a speech, the 22 a day message began to have diminishing returns. The term illustrates an example of semantic satiation, a psychological phenomenon in which repetition causes a word or phrase to lose its meaning to those who hear it. The Prevents initiative helps by shifting the narrative to one that's fresh and more inclusive. Veterans are a part of a broader society where suicide is a problem at large. About 123 Americans die by suicide every day, with 20 to 22 being veterans and service members. So we are urged to see the problem beyond the isolated context within which we talked about veteran suicide. The reality is, suicide remains high among other groups, like police officers and teenagers. So a campaign on suicide will be more effective as one focused on public health in general, as we've seen with smoking, drinking and driving, and domestic violence. This way, society as a whole shares a burden, not just government agencies and healthcare systems. Recommendation number 2, identify and prioritize suicide surveillance and research that focuses on a veteran's unique combination of individual, social, and societal factors to deliver the most effective interventions tailored to meet their needs and circumstances. No one size fits all in terms of intervening for veterans in crisis. For some, the problem is largely clinical. In those instances, a mental health diagnosis can be linked to behaviors and can be treated through traditional means, such as medications and therapies. But many suicides catch us by surprise because the individual showed no signs, symptoms, or red flags. In those cases, I argue it's a matter of spiritual brokenness, where a pill or cognitive-based therapy isn't the answer. Evidence-based approaches are a good start, but don't always take into account race and gender. So access to complementary and integrative health services that offer multiple options among traditional and innovative practices is how you restore multiple dimensions of a veteran's existence, not just a chemical imbalance that causes depression. Oftentimes, veterans will tell you what they need, and it becomes a matter of whether they're offered it. We can also treat veterans more precisely by adding biomarker research to inform providers of potential reactions to medication or the extent of a trauma based on what DNA has recorded. It is these multifaceted, multidirectional ways we can personalize a problem with the veteran at the center that should be the rule, not exceptions based on where a veteran happens to seek treatment. Recommendation number 3, promote foundational changes to the way research is conducted, including improving the speed and accuracy with which research is translated into practice, improving efficiency through data sharing and data curation practices, and using innovative funding techniques to drive team science and reproducibility. Right now, as we're confronting the novel coronavirus pandemic, we're watching a case study on what it looks like to treat a crisis like a crisis. The public understands its role by wearing masks and social distancing. We have a way to measure success by watching rates of death and survival, as well as a curve that needs to flatten through our collective efforts. We also know the research for a coronavirus vaccine has sped up as scientists race to understand the coronavirus. The process of designing experiments, collecting data, and bringing forth relevant studies for expert review are being compressed drastically. What typically takes many months is happening in weeks. So we know it can be done, but it requires a demand from taxpaying citizens that our elected leaders literally do whatever it takes to get the job done. This also means looking at different ways to collect ideas and fund research. For example, we've seen crowdfunding work in charity fundraising and real estate. The same approach could help close a gap between startups that just need a chance to realize its full potential and academia that heavily emphasize body of work and generally accepted rules of engagement. By having the public more involved, it democratizes the opportunity to turn ideas into results and with the public as the top investor. Recommendation number 4, develop effective partnerships across government agencies and non-government entities and organizations to increase the capacity and impact of suicide prevention programs and research to empower veterans and prevent suicide. Silos only work on farms and military bases with missiles. They don't work well when agencies share aspects of a problem but prioritize it differently. Veterans and service members are touched by just about every federal agency, yet the only ones that have highly visible programs for veterans are the Departments of VA, Defense, and Labor. But agencies need to be not just aware of all the programs for veterans offered by the federal government, they also need to interconnect in meaningful ways. The IRS has veteran-specific tax policies that could impact employment and access to certain VA benefits. Junior enlisted service members are eligible for service and assistance under the Department of Agriculture SNAP program. Veterans can get help with starting a business through SBA. The Consumer Protection Bureau has programs that protect veterans from fraud and identity theft, and these are just a few examples. But if all these agencies work in isolation of each other, the veteran is seen as 7 or 8 different people trying to access services instead of one person in transition trying to pull his or her life together. Recommendation number 5, encourage employers and academic institutions to provide and integrate comprehensive mental health and wellness practices and policies into their culture and systems. It's hard enough to return from combat or a hardship deployment, or even just serve 4 years on active duty and simply return to normalcy with family. These same veterans must also find work or, if necessary, undertake higher education to enhance one's value in the workforce. The problem is a 26-year-old who went straight from high school to college and is looking for work is much different than a 26-year-old veteran who served in combat and managed to piecemeal her education between deployments and work duties. When society treats these men and women like strangers in their own society, primarily due to a lack of cultural competency, it presents a problem for veterans who simply need to be better understood and supported to get through an academic education plan and graduate or excel in the workplace. Recommendation number 6, provide and promote comprehensive suicide prevention training across professions. One of the hard lessons we learned in the wake of the wars in Afghanistan and Iraq centered on traumatic brain injury. It's an invisible wound that manifests in certain antisocial behaviors, which in turn elicit reactions from those who don't understand it, that results in isolation for those veterans who may not even be aware of or control the way TBI influences what they do. Addressing the problem entailed having any VA staff that works with veterans become more aware of TBI through all-hands training. That way, not only did it increase the likelihood that staff person would be equipped to help a veteran with an undiagnosed TBI, it also made everyone in the system an invested partner in solving the problem. The same approach can happen in suicide prevention once everyone who may encounter a veteran who's suffering has basic tools to see the red flags, intervene on some level, and connect that veteran to the appropriate level of care that he or she needs. Recommendation number 7. Identify, evaluate, and promote community-based models that are effectively implementing evidence-informed mental health and suicide prevention programs across the country. In doing so, they should leverage relationships with community-based efforts, nonprofit organizations, faith-based communities, VSOs, and MSOs focused on saving the lives of veterans. The VA implemented the VA Mission Act last summer, which expanded care in the community for those who need urgent care or are better served by care outside VA for certain reasons. This broadened the scope of veteran engagement into areas where veterans hadn't been served in significant numbers as a cohort. The community is more than just healthcare paid for by the VA. It involves organizations that connect veterans with peers to give them a sense of purpose and belonging. Religious institutions are important protective factors that address spiritual restoration, which is often underregarded as an aspect of a veteran's reason for living. Making veterans whole again often requires a collective impact approach that restores the whole person, not just lower order needs having to do with the basics of living like housing, health, and employment. Recommendation number 8. Increase implementation of programs focused on lethal means safety. For example, volunteer reduction of access to lethal means by individuals in crisis, free and inexpensive, as well as easy and safe storage options. We know that using a firearm to die by suicide is the number 1 choice among male veterans, number 2 choice among women veterans, followed by self-poisoning, and women veterans are more likely to die by suicide using a firearm than non-women veterans. We also understand and appreciate our constitutional right to legally possess a firearm, so finding balance in how we deal with the risk of suicide by firearm is critical. From the time someone chooses to die by his own hand and picks up a weapon to act on that impulse is a moment of consequence. The best chance to stop someone is to slow down the time it takes from thought to action by putting things like gun locks, phone numbers to resources, education materials, photos of family, and other interrupters that may delay suicide long enough to get the individual to rethink the choice. This also includes access to bridges, self-strangulation, self-poisoning, and other commonly used lethal means. We won't be able to anticipate all the different ways a person may be thinking about ending his or her life, but we need to learn from the past by building in as many protective factors as possible around an individual at risk. Recommendation number 9. Develop a coordinated interagency federal funding mechanism to support, provide resources for, and facilitate the implementation of successful, evidence-informed mental health and suicide prevention programs focused on veterans and their communities at the state and local levels. Budgets are often the best evidence of what a government agency prioritizes. We need to see priorities related to confronting and curbing veteran suicide. This includes creating staff positions whose purpose is to connect across agencies and marshal collective efforts. Last but not least, recommendation number 10. Streamline access to innovative suicide prevention programs and interventions by expanding the network of qualified healthcare providers. More and more providers will encounter veterans as care in the community continues to expand. This means more opportunities to move a veteran off a self-destructive path to a pathway that leads to supported, sustainable programs that exist for the purpose of saving lives. The key is to cast nets with fewer gaps through which veterans often fall. I'd like to thank all of you who joined us for this presentation on the Prevents Roadmap, where we discuss the recommendations. Tomorrow, we'll discuss part 2, where we'll talk about implementation. Thursday, we'll talk about the final part, evaluation, which is perhaps the best measure of whether we've been successful or not. I hope you join us in our effort to heal American veterans. Hi everyone, my name is Sherman Gillums. I'm the Chief Advocacy Officer for AMVETS. If you caught our first video, we talked about the prevents roadmaps and the recommendations that set the stage for what will be the next part, which is the implementation strategy. This is part of a plan to change the environment and culture around suicide prevention that will be enforced over the next 2 years and then evaluated. We'll start with the first one, organize. Ensure the infrastructure and engagement required to plan, implement, and evaluate and sustain all recommendations are in place. Let me break that down for you. This requires the passage of certain laws like S 785 and HR 3495 that focus on resourcing community organizations that confront veteran suicide. Once passed, these laws only work once agencies take them for action and carry out the intent of Congress, with the public playing a key role. Number 2 is assessment. Collect, standardize, analyze, and report data regarding the individual, community, state, and federal landscapes. Data drive everything in terms of measuring success in the fight against veteran suicide. The problem is too much inconsistency and variability in how data are collected, starting with how cause of death is determined at the city and county levels and how veteran status is determined by medical examiners and coroners. At present, there are also barriers to separating cases of overdose and high-risk behavior resulting in death from a clear act of suicide. Finally, there exists a 2-year lag in data interpretation. If this continues, we won't know anything about the impact of the pandemic until 2022, which bears diminishing value as it ages. Number 3 involves planning. For each of the 4 areas of focus in the Prevents Roadmap, programs, policies, research, communications, develop an execution plan that includes role specification, major tasks, timelines, security and privacy safeguards, resource requirements, implementation support requirements, process and outcome evaluation plan, and risk and contingencies. This phase of the roadmap is the least sexy, but most important because it focuses on the real work, the part of most major undertakings that scares people off, quite frankly. Dealing with suicide prevention is draining, laborious, and seemingly futile at times. But just like preserving our environment and preventing terrorism, it takes the entire country to contain and act in the interest of the greater good. Sometimes getting things done starts with looking less out of windows and more into mirrors. The next 3 components of the implementation section deal with execution, evaluation, and sustainability. These are all part and parcel of taking the roadmap out of the abstract and making it 3-dimensional. It is also important to make adjustments when necessary at the evaluation stage so that the plan evolves with the need. A plan that cannot be changed is a bad plan. I want to thank all of you who joined us for parts 1 and 2 of our discussion on the Prevents Roadmap, where we first talked about recommendations and now the implementation. We hope that you join us tomorrow for part 3, where we'll end this discussion with a focus on evaluation, perhaps the most important part of any plan and measure of success. We hope that you'll join us as we continue to work to heal American veterans. Hi, my name is Sherman Gillums. I'm the Chief Advocacy Officer for AMVETS. If you saw our first 2 videos on the Prevents Roadmap, we talked about recommendations and implementation. In the third portion, we're going to talk about evaluation. This portion of the roadmap measures how this multi-year process fared through 4 principles and measure if it's successful enough to be implemented as a blueprint for preventing suicides amongst all Americans. Number 1, recognize that the Prevents Roadmap is a living document. I often say vision without execution is hallucination. The roadmap's purpose is to serve as a guide to taking actions that will be put to the test, affected by externalities, and rely on human behavior. For that reason, those charged with executing it will benefit most by operating with the strategic agility necessary to carry out the spirit of the roadmap, even if the letter of the plan must change. Number 2, coordinate the evaluation process using experts in diverse fields that share a commitment to process. Measuring results has to be less about simply taking anecdotes and making them data points on a trend line, and more about telling a deeper story that reveals why people choose to die. Information alone does no good. That information must somehow flower into knowledge that drives change in the only metric that counts in the final analysis, the number of deaths by suicide. Methods, treatment protocols, and rules of engagement among experts only matter to the extent they collectively impact the bottom line. When the numbers don't move or worse, increase, we need to know why, not simply relish in the complexities of suicide. Number 3, use a model to integrate understanding of the individual, organizational, and societal impact of each strategy on its own and in combination. Human beings are complicated, and so are their needs. Thus, knowledge transfer laterally and vertically are critical to increasing our understanding of the reasons people choose the permanent solution to what are often temporary problems. Collective impact begins with the multifaceted needs of the individual and extends to the benefits enjoyed by society as a result of integrated efforts. And finally, number 4, develop a system to collect, analyze, and report evaluation data quickly and efficiently. The 2-year lag in data is an impediment to making timely changes in how we tailor policy to evolving changes, especially unpredictable factors that can impact suicide rates, such as the pandemic, social unrest, barriers to accessing care, and incessant negative breaking news in cable media. I thank all of you for joining us in this 3-part series where we discussed the Prevents Roadmap. First, we talked about recommendations. We then covered implementation, and finally, evaluation. Now the real work begins. We hope that you'll join us in our mission to save lives and heal American veterans. We can't do it without you.